afternoon, everyone. I can see that we have participants joining, so I'll just give people another minute or two to log on. Okay, I think we'll make a start. It's a great pleasure to announce this month's Grand Round. So we are focusing this month on how I treat Wiskott Aldrich Syndrome. My name's Siobhan Burns. I am a consultant immunologist looking after adult patients at the Royal Free Hospital in London. And I have with me today a number of experts in the field, and we have people who are going to both present and be on our panel to answer your questions. So it's a great pleasure to introduce Alessandro Aiuti. Alessandro is known to many of you, and Alessandro is the Deputy Director of the San Raffaele Institute in Milan and the Director of the Paediatric Hematology Unit. And welcome, Alessandro. Alessandro will be on the panel with us later, giving us his expertise. So I'd also like to introduce our speakers for today. So Michael Albert probably also doesn't need much introduction. Michael is a professor of pediatric hematology and oncology in Munich, and the head of the stem cell transplant program there, and has published a lot of research in Wiskott Aldrich syndrome, and will be also giving his opinion about how to handle our tricky cases today. I'd like to introduce Francesca Ferrua, who is a staff pediatrician at the San Raffaele, who's going to talk to us about gene therapy. Lizzie Rivers, who's an consultant in pediatric immunology at Great Ormond Street. Lizzie's going to present a tricky case for us. And Khuloud Alsehaim, who is a clinical fellow with us here at the Royal Free in London. Khuloud is an clinical immunology trainee in Saudi Arabia, and is also going to be presenting a difficult case. So I'm not going to take up any more time because we have a pretty packed program, and I want to allow time for panel discussion and for you all to put your questions in the Q&A. Just a note to say that when you are putting your questions in, please use the Q&A and not the chat function. We will have some panel discussion after each of the talks, but we are going to deal with the questions and answers from the audience at the end of our
Siobhan seems to be frozen.
I was just going to say,
there she is.
You can put them in as we go along, and we will get to them at the end. So Michael, with no further interruption, would you like to go ahead and present your talk today, which is going to really be the backbone on which we have much of the rest of the discussion?
Okay, thank you, Siobhan, for the kind introduction and the great introductory words, and for putting together this round, which will be exciting. I will try to stick to time, therefore these are my disclosures really quick. And this will be the agenda of my talk. I will talk to you about the clinical spectrum of Wiskott, which is spelled with a K, by the way. There was a typo on the first slide. I will talk about the different treatment options, the results of our recent natural history outcome study, results of transplant, and how we interpret these findings, and then we'll have a panel discussions. So I won't have to bore you much with the manifestations of Wiskott Aldrich syndrome, which are, of course, 5: thrombocytopenia, eczema, immunodeficiency across pretty much all cell lineages, autoimmunity, and a predisposition to malignancy. Not all these manifestations are occurring in all of the patients. The only one that is really omnipresent is the microthrombocytopenia. There are only very, very few patients who have a milder and more intermittent thrombocytopenia, but the general rule is that a patient with Wiskott has thrombocytopenia. All the other manifestations are very variable, and it has been known for a long time that this disease has a large spectrum of severity. which is why Hans Ochs and colleagues first introduced this WAS score with a score of 0 to 5, with 0 reserved for the X-linked neutropenia variant, which we will not talk about today because these are patients who have likely gain-of-function mutations in the Wiskott gene and have a different phenotype. So 1 to 5, 1 and 2 usually reserved for those patients with a milder phenotype with mainly thrombocytopenia, only maybe some eczema and maybe some immunodeficiency and milder infections. 3 and 4 for the more severe forms, and 5 for those patients who have additional autoimmunity or malignancy. However, this score is good for describing current disease severity, but it's helpful for categorization within studies and manuscripts and so on, but it shouldn't be used for treatment decisions. And it's also not very useful in patients below the age of 2, which actually is the most important age, because many of our Wiskott patients these days are diagnosed within the first few months of life, and then treatment decisions have to be made soon. This is another slide to describe the disease severity spectrum, and what I want to bring home with this is that there is a quite high likelihood of progression to a higher score with age, and it's a very common thing to see. It can occur at any age and suddenly, and there can also be interruptions, like patients with a very mild phenotype progressing to a score of 5 by developing some severe autoimmunity or malignancy. And it's also important to note that there's a relatively large variability even within families. I will only spend this one slide on the conservative management of Wiskott. We have recently summarized this in a How I Treat manuscript in Blood, so you can look it up there. And basically, all conservative management approaches can be done for thrombocytopenia or bleeding. One caveat is that platelet transfusions should not be given as a prophylactic measure. They should be reserved for active bleeding or surgical procedures to avoid the risk of alloimmunization. And splenectomy, we'll also discuss later, I believe, is something that is less frequently used these days because of the increased risk of fatal infection after splenectomy. Infections are controlled with antibiotics, sometimes immunoglobulin replacement, vaccinations. Eczema follows treatment guidelines that are there for atopic eczema, and autoimmunity is usually controlled by corticosteroids. Some autoinflammatory manifestations can nicely be attacked by IL-1 blockade, and rituximab can be useful for antibody-based autoimmunity. And malignancy treatment should follow normal oncology protocols. So we, almost 2 years ago, published a study that we did in the year 2014, where we assessed 577 Wiskott patients across the world who were born between 1932 and 2014. So it's also quite a historic cohort in a way. And we asked for wanted to get an overview of the disease burden in these patients and wanted to quantify the risk for disease-related events. And we hypothesized that there could be genetic biomarkers that could help to define the risk profile, and I will show these results. So overall, the survival for patients censored at transplant or gene therapy is still not that great in Wiskott Aldrich syndrome. However, almost half of the patients, or about half of the patients, reach age 30 even without transplant or gene therapy, which is interesting. And this is also an improvement compared to historic data, which may, on the one hand, reflect improvements in treatment approaches, in conservative treatment approaches, but may also reflect that these days more patients with a milder phenotypes are being diagnosed as Wiskott via as compared to historic data sets where they might have been categorized as ITP. We know from a study we did in 2010 that some variants, missense variants in exons 1 and 2, and this specific very frequent intronic variant in intron 6 are ones that are usually associated with milder disease. They usually allow for some degree of protein expression and therefore are frequently found in patients with what we used to call an XLT phenotype. So for our study, we grouped all these variants as class 1 and all other variants we put into class 2, and I'll show you the difference in outcome. If we look at overall survival, we see that patients with a class 1 variant have a much improved overall survival compared to those with a class 2 variant. However, you can still tell that this is not a normal survival curve compared to a normal healthy population. So for 30-year-olds, the probability to be alive with a class 1 variant is 91%, while in the normal population it would be 99%. So they're clearly, even the class 1 disease is a dangerous and potentially fatal disease. If we look at the disease-specific complications or events, we looked at severe bleeding, severe infections, autoimmunity, and malignancy, and we are really talking about life-threatening events in this case. So, for example, meningitis, pneumonia with respiratory support, fatal or dangerous bleeding, intracranial bleeding, bleeding requiring red blood cell transfusion. So if we look at that, it's becoming very clear that the patients with the class 2 variants have a more severe phenotype with an earlier, significantly earlier onset of severe bleeding, severe infection, autoimmunity, but not malignancy. But if you look at the cumulative incidence curves for the patients with the milder class 1 variants, you can see that the overall cumulative incidence of these severe events is pretty much the same, only they do occur a few years later, usually about 10 years. And if we take all events together, this becomes even clearer. So this is the incidence of any severe event within the class 1 patients, and these are the class 2 patients. So even the other way around, class 1 here, class 2 here. So even in class 1 patients, the cumulative incidence of such a life-threatening event would be about 70% by age 30. I will now switch to the transplant outcome, since stem cell transplant has for almost 50 years been the treatment of choice for patients with Wiskott Aldrich Syndrome if a matched donor was available. This is the most recent EBMT analysis with almost 200 patients who received either a busulfan or treosulfan-based conditioning regimen, and you can tell that the overall survival all in all is very good, especially if you have a matched sibling donor, which is the red line. It is still necessary to note that age at transplant matters for the outcome. This is a cutoff that has historically been established at 5 years, and it's still significant. However, if we look at the hazard ratio for overall survival, you can note that it only slowly increases over time or with age, and then really only in adulthood the risk of transplant really goes up. So this 5-year cutoff is not one that's really useful in the clinic. So it doesn't mean that a 4-year-old has a worse prognosis than a 6-year-old boy. It depends much more on organ damage or active infections at transplant or donor quality. We could also show that both the Buflu and the Trioflu regimen have the identical survival, but there is a higher incidence of graft failure or less complete engraftment if treosulfan is used, and more secondary procedures have to be performed. So all in all, survival of Wiskott patients after transplant has improved and likely continues to improve for all donor types. This includes haplo. About 14% of the patients in this study received a haplo transplant, and we could show that conditioning intensity is important, which was also shown by the US American group at just 1 year before. Here in Munich, we use a fully myeloablative busulfan-based regimen with fludarabine and alemtuzumab, and we've recently summarized our last 20 patients using this protocol from a mixed bag of donors, a few of them mismatched, but mostly matched siblings and matched unrelated donors. And all these patients survive. We have a high event-free survival. There was one graft failure in one patient who needed a second transplant. We have a very low incidence with only one patient developing chronic graft versus host disease, resulting in a GVHD-free, event-free survival of more than 80%. And if you do something that is not allowed statistically, the patient that received a second transplant here and the patient who resolved his chronic GVHD, 100% of these patients are currently GVHD free of all immunosuppression and are surviving disease free. One slide only on gene therapy, because I know that Francesca will be showing similar things later in more detail. This is the last summary of all the patients treated with lentiviral gene therapy approaches, most of them in Milano, but some in London, Paris, and Boston. And 44 out of these 47 treated patients are currently surviving with very good reduction in infection and bleeding. And Francesca will show you more details from the Milano cohort later. So in theory, if you compare the two definitive management options, gene therapy and transplant, it's very hard to say one is better than the other because we have no comparative studies and they are different in a number of respects. The big advantage of gene therapy is that you don't need a donor because it's an autologous procedure, which also results in an absent risk of graft versus host disease. However, at the moment, the access to gene therapy is very restricted and therefore difficult. Chemotherapy is almost the same. On the other hand, for transplant, we know that the efficacy is excellent in the short and in the long term, but we do have some mortality associated with HSCT, which is very likely higher than the one with gene therapy. And of course, all the negative consequences of alloimmunity can play a role as well. So with this, I'll come to my summary slides. And I have shown you that the type of genetic variant is a predictive biomarker, which can be used to predict disease severity and survival in Wiskott. And those patients with class 1 variants do still experience a later onset of disease-related complications and remain prone to morbidity and premature mortality. And severe complications can occur at any age, even in patients with these class 1 variants. Therefore, we suggest not to use the term XLT anymore or mild WAS because these labels, once they are put onto patients, they will have an influence on future treatment decisions, even though these patients may long have become more severe Wiskott patients. So we really discourage the use of these two. Outcome after transplant and also after gene therapy, as you will be shown, is very good and improving, even for older patients. I didn't talk in detail about that, but that's also a fact. And this should open the discussion about transplant or gene therapy for any newly diagnosed young Wiskott patient, regardless of his current disease severity or genetic variant, because I think we are now in an area where we can offer preemptive transplant or gene therapy to these patients. And also older patients who previously had a milder course but who have disease progression like severe autoimmunity or something else should be considered for definitive therapy. Severe risks of these treatments still remain, but the disease itself is probably worse. And an individual risk-benefit assessment has to be performed for every patient, which we will do for the patients you will present it later on. Thank you very much.
Great. Thank you very much, Michael. That was a really fabulous start to the session. So I'm going to suggest that maybe the panelists and Alessandro will put your cameras on for now. And I'm going to ask, I'm going to start with asking Michael a question, because I guess in some ways the whole paradigm around how you assess a patient with Wiskott Aldrich syndrome is changing with the advent of better understanding of genetics, the ability for us to measure WAS protein, for example. And while in the past we may have relied on the clinical score, we're now basically saying the clinical score isn't actually that useful for making treatment decisions. So how do you, when you see a new patient, and Alessandro, I'm going to ask you the same thing, when you see a new patient with Wiskott Aldrich syndrome, say early in life, in the first 2 years, how do you make your assessment about what your initial treatment strategy with the family is going to be?
Yeah, thank you. Important question and quite frequent scenario. So what we do in all patients, we assess all the disease manifestations and give them the best treatment, conservative treatment that they need. That's obvious. But then we sit down with each and every family and discuss the opportunities of a curative therapy, in our case, transplant, because gene therapy is not yet accessible. Because we know that even the patients who have almost no symptoms, maybe only thrombocytopenia, they do have a high risk of later on progressing. Of course, a lot of factors play into these discussions: donor availability, willingness of and understanding of the family to embark on a potentially dangerous procedure, and so on and so on. Things like infertility and stuff like that. So these can be very difficult discussions, and they are never the same. It really depends on the family.
Okay, I have a follow-up question, but I'll ask Alessandro the same question. Alessandro, how do you manage? How do you? What information do you use at the beginning to inform how you're going to manage the discussion with the family with the new Wiskott?
Yeah, thank you, Siobhan. And we're, of course, on the same line of Michael. I would say that we also try to collect all possible information about the potential evolution of the disease, especially if we are on patients which are, let's say, have apparently milder phenotype in terms of mutations, WASP expression, immunological phenotype, T cell function. There are typically alterations in the proliferation test to anti-CD3 and autoimmune antibodies. So in some ways, these, of course, are not defined biomarkers, but we're trying to understand better this. But we do offer for all patients the option to consider allogeneic transplantation or gene therapy, autologous gene therapy, stem cell gene therapy. And
Okay.
this families pros and cons, yes.
And presumably for families who, in what situations would you recommend right from the get-go that really strongly the best alternative is to have a corrective procedure? Would you recommend that for all children who come to you with Wiskott, or do you make some assessment of severity based on something?
I think we discuss with the available option. I think all patients would deserve to discuss and evaluate in terms of future for the children, especially with families that they may have, fear that once the patient becomes a young adult, an adult, and the parents will not be longer there. They would like to have a definitive treatment. So I think we have to consider, based on the data that Michael showed, that the long-term outcome of untreated was, even in, let's say, milder form, has some important risk that we need to consider. So I think, well, of course, it's obvious for patients with severe mutations and phenotype which is severe. We do discuss the options, and in some cases it's watch and wait and see for some time. But I think it's proper to discuss all the possible options, including the conservative ones, and that's upon also on the family to decide eventually. Yes.
Okay. And just for both of you, do you measure Wiskott Aldrich Syndrome protein expression for all patients who come, or only for patients that have a mutation that hasn't been previously described? What's your approach to that?
In our case, we do measure the expression by flow cytometry in all patients, as potentially there could be some individual variations, even if they are already described. So it's an important, let's say baseline. Also, of course, if you do gene therapy, you want to see that there is an improvement and a change, and having a reference. Also because in some cases you may find surprises such as revertants and populations which are there, which express normal levels but are revertant. So I think having the whole picture, what is the situation, is important for all patients.
Yeah, I can only add that we also do that in all patients, but in many cases it's more out of curiosity, and it doesn't really add to our treatment decision algorithm more than anything else.
Although if the expression is completely absent, does that sway you in terms of how strongly you suggest treatment to stem cell treatment, or not necessarily in your case?
Yeah, well, in our experience, this is really only the case for the class 2 variants, and
Right.
for these, we recommend a definitive treatment from the best available donor as soon as possible.
Okay, so the class 1 variants are a bit trickier. So the other questions I have just before we move on to the next presentation, because some of these will come out in the presentations, are just conservative management. So I think, Michael, you said that you discuss conservative management with all patients. What does that involve? And do you start all patients on immunoglobulin therapy?
No, we don't. Only those who have hypogamma or show insufficient response to vaccinations. Or have recurrent infections, of course. Yeah.
Alessandro, do you have anything else to add to that, or do you do the same?
Yeah, I mean, of course, it depends on the immunological function and the antibodies and the antibody levels. Usually, most of the patient would require immunoglobulin replacement therapy, and we use a similar approach.
Yeah. And I mean, even if in a very small patient where we decide we're going to transplant him anyway in 6 months' time, we put them on immunoglobulin replacement just to keep them safe until transplant, because we don't want them to come into transplant with some virus problems, even if they don't have hypogamma.
Okay. Excellent. All right, let's move on. So I think, Lizzie, you're next. So if Alessandro and Michael can just turn your cameras off. Lizzie, if you turn your camera and your microphone on, and Lizzie is going to present to us a pediatric presentation with XLT in brackets, as Michael's already said. We're moving away from the term. Right, Lizzie, go ahead.
Thank you very much. And yes, thank you very much for the invitation to join your discussion today. So I'll be presenting a pediatric case from Great Ormond Street, actually led by my consultant colleague, Austin Worth. So this is a boy, he's now 11 years old. He presented at the age of 6 with persistent hematuria and a background of familial thrombocytopenia with a mildly low platelet count, but always more than 75. So mild eczema, asthma, and hay fever. And he was found to have a rare tumor of the bladder comprised of myofibroblastic and fibroblastic spindle cells interspersed with a mixed inflammatory infiltrate. This is a type of tumor associated with mucosal sites, but not particularly described in the Wiskott or XLT literature as far as we're aware. However, thankfully, he responded completely to a course of targeted therapy and has been in remission for the last 5 years. In terms of the Wiskott diagnosis, so he was referred from the oncologist to the hematologists to explore this familial thrombocytopenia. And this is where a mutation in WAS was detected, and hence he was referred to our team. This was a missense mutation in exon 10, affecting the BCA domain. He has normal WAS protein expression by flow cytometry, and Western blotting showing not a significantly truncated protein. He's got no significant infections in his history. So as discussed before, very difficult to assign a Wiskott score to this kind of a case, depending really on how much weight you put the diagnosis of malignancy being related to his Wiskott mutation or not. And that becomes quite important when you look at his family history. So this is him at the bottom here, 11 years old. This is his brother, older brother, 15. He also has a slightly low platelet count, a more significant history of atopy, and required some immunotherapy to control his hay fever and asthma. Interestingly, one previous episode of Henoch-Schönlein purpura, but that resolved completely spontaneously with no lasting renal impairment or proteinuria. He's got 2 maternal uncles who are fit and well as adults. They both have a slightly low platelet count, which has only ever been slightly low, uninhibited in their activities. At least one of them is a father, and they've not required any medical intervention at all. One of them is a professional rugby player. Also important in the family history, we've got a maternal great-grandmother who died young at 46 with a skull carcinoma, maternal grandmother who died at 50 of a spinal carcinoma, and maternal grandfather with Castleman's, none of whom have a platelet problem. So in summary, this is a boy who already presented over 5. He has a mild phenotype in terms of infection, no significant infections or autoinflammatory disease, no autoimmunity. Quite a reassuring family history from a thrombocytopenia point of view in the older family members who've always continued to have only a mildly low level. And potentially an impact of an additional cancer susceptibility in this family. Yes, he does have a diagnosis of a malignancy, but has been 5 years in remission and responded completely to a targeted therapy. In terms of his activity, he's completely uninhibited. He currently is very active, enjoys judo and rugby, and has had no significant bleeding or bruising related to this. Academically, he's doing very well and wanting to pursue a career in space exploration and aiming to go to one of the UK's top universities. So, Susanna, if you can help, what I wanted to do is share a quick poll of thoughts about what would be your management approach for this boy. And if you could please select watch and wait, stem cell transplant, gene therapy, thrombopoietin agonist, or splenectomy. And I'll just give people a few seconds to answer. Aha. Okay, good. A mix of answers. So just for fun, I'd like to repeat the question for the patient's brother who's older, who doesn't have the malignancy diagnosis, to see whether that changes people's opinion. Okay, interesting. So more of a watch and wait without the malignancy diagnosis. Okay, thank you. So our approach for this sort of patient has been for a watch and wait. In our overall cohort of more than 100 patients across all disease severities, we have quite a low bleeding risk, and almost all of these patients with significant bleeding has been in the context of autoimmunity and a sudden drop in the platelet count. We do consider thrombopoietin agonists, and we have recommended splenectomy or considered that in cases where this has not been effective or where there's been significant impact on quality of life. This is not a discussion that we undertake lightly and involves significant counselling with the family for the long-term risks. We're quite aggressive with the management of looking for vaccine antibodies and promoting lifelong need for antibiotic prophylaxis. Importantly, we haven't found splenectomy as useful in the long term in the context of autoimmunity. And at our centre, a diagnosis of autoimmune thrombocytopenia would preclude the diagnosis of an XLT or a mild Wiskott. In those with autoimmune thrombocytopenia and who had splenectomy, we had a 50% risk of relapse of the thrombocytopenia after splenectomy. As with other centres, our survival post-transplant at our centre has been very good, but we do see a 25 to 30% risk of autoimmunity or autoinflammatory disease post-transplant, usually in the context of a mixed chimerism. And we need to balance the risks of GVHD and late effects after transplant. We do have a handful of patients in the middle of this spectrum, however, and they can be difficult to predict the severity, as we've heard. So what do we use at our centre to help predict severity? We do use WASP expression and can find it quite useful, particularly in the absence of WASP expression, which is associated with more severe disease. Of course, we have to remember the different methods for protein expression detection. And in the bottom line is an example of such a case who presented with a very mild disease phenotype with just a low platelet count, but surprisingly had absent WASP expression by flow cytometry. And on the right, you can see the Western blot showing that protein was detected, and this actually ended up being a missense variant that affected the epitope binding of antibody for flow cytometry. So that was quite an important lesson for us. In terms of functional analysis, we don't do this routinely for all our patients, but it can be useful. This is looking at podosome analysis for patients with Wiskott mutations. Podosomes are the actin-rich structures shown here as the red dots associated with vinculin here, integrin binding proteins. And these are typically completely absent in patients with severe disease phenotype that we would offer transplant to. In contrast to this, on the far right-hand side, you can see a patient with a very mild disease phenotype who does have podosomes, although the morphology does look different to the healthy donor. And finally, I don't have time to talk in any great detail, but just to mention that with the advance and understanding of the role of WASP in mitochondrial homeostasis, whether we should be looking more at the metabolic state of the immune cells and whether this can be used to predict early immune senescence or T-cell anergy, and whether that can also be used as a predictor for those who are likely to have a decline in their immunology with time. So for the future, I think ongoing international collaboration and discussion of such cases is essential to really tailor care. I think we do really need the long-term follow-up data of thrombopoietin agonists and of gene therapy to be able to really evaluate all therapeutic options for even those with the mild disease phenotypes. And now I think we'll hear some thoughts from the panel on this particular case.
Great, thanks, Lizzie. Lizzie, if you could leave your camera on. I've got a question for you just while Michael and Alessandro are joining us back again. You talked about autoimmune thrombocytopenia, I guess, as opposed to the congenital thrombocytopenia that we typically see in Wiskott. How do you make that diagnosis?
Yeah, so I think we spend quite a bit of time in looking at response to therapy. So I think the first thing to say is actually between our two cohorts, just the degree of thrombocytopenia wasn't different in the severities, so not the lowest. But if you had a sudden drop or a drop that was associated with illness, for example, looking at response to IVIG or steroids or platelet transfusion. And actually in those patients who are being treated for an autoimmune thrombocytopenia, looking at a 1 hour post-transfusion increment and then seeing several hours or 24 hours later how quickly those platelets have been consumed. So that's one factor. And the other factor is a suspicion when there are other autoimmune cytopenias like a hemolytic anemia or a neutropenia that might raise our index of suspicion to look for thinking about autoimmune thrombocytopenia in these patients.
Okay, thank you. And I guess onset of bleeding, new onset of bleeding usually prompts at least a thought about that.
Yes.
Michael first, and Alessandro, do you want to chip
Yes,
in
thank
your
you.
bits?
Very interesting case. The mutation you reported for the variant you reported for this patient is actually a peculiar one because it's a missense variant relatively downstream in the gene, which should in theory result in absent protein, but you have shown fully normal protein. And this patient doesn't have and that the mutation has not been described before, and the patient has kind of a peculiar phenotype for Wiskott. So did you explore more broader genetic testing if maybe this is not even a Wiskott patient after all, and you may have something else or an additional tumor predisposition syndrome, which is also suggestive given his family history with these strange mesenchymal tumors.
Yeah, I think, yes, we've had all of those thoughts. I think just going clinically about what does it mean and what does he need, I think there's been enough of a response to treatment and that he's well, that we've been satisfied with a watch and wait, but with, frequent review of what would be the treatment options. I think this missense mutation, although rare, it has been reported in 2 other cases, non-related, who had a mild spectrum of Wiskott. I don't know what age that was reported or what happened to them later on, but there are certainly two case reports of the same variant.
And Lizzie, have there been any other genetic studies for alternative cancer-causing genes in this family?
I'm not sure, actually. I'm not sure about that.
Okay. Alessandro, you had your hand up.
Thank you, Lizzie. That was really interesting. I had the same question of Michael, but if I wanted to elaborate more, I mean, this is probably at the spectrum of if it's Wiskott of the really milder form because the protein is there. But I wonder if you checked by flow cytometry if there is WASP expression in different subset, whether you have excluded revertant, and whether you've done additional studies to investigate the function of the T cells in this patient. Yes.
No, I don't think so. His immunophenotype, I think, is normal, which would be consistent with not having severe infection. I'm not sure that we've done proteosomes. I'll have to check. As I said, it's not part of the clinical lab tests. It's done on a research basis. So I'm not sure that we have done that. I haven't done it myself. But potentially that could be useful. If it's slightly strange looking proteosomes, I would be very surprised if they were absent, given the clinical phenotype, but potentially something that we could review. But if you think that there's something that we should be doing or investigating, we're very, very happy to take the suggestion, because these cases are very tricky and implication potentially of several family members. Yeah.
Yeah, because in our case, I mean, we have never considered we have never been referred patients for gene therapy which had completely normal WASP expression. So this would be very unusual also for us to consider, for example, for gene therapy. Yeah, of course it would be a healthy protein and as compared to a defective one, but the expression is.
If you could show, do you think if you could show that there was a functional problem for sure with the Wiskott protein, do you think in the future with the long-term data for gene therapy that we should start considering gene therapy for milder clinical severity?
Yeah, potentially, yes, if you showed a functional defect that could be corrected potentially with the normal wasp protein. But of course, this case is very peculiar. In general, I mean, we have treated patients with, which is the interesting of your presentation. We've treated patients with had reduced or absent wasp expression. So yeah.
Lizzie, just one question. Was there consanguinity in the family or no?
No.
No. Okay. So Michael and Alessandro, I'm going to put you on the spot. Michael, how did you vote for Lizzie's poll?
I couldn't vote.
How would you have voted if you could have voted?
would have, if I was convinced this was really Wiskott, I would go ahead and transplant him or offer transplant to him, but I'm not 100% convinced he actually has Wiskott.
Okay, and what about the brother? What would you have done for the brother?
Same, I would offer transplant.
You'd do both. Alessandro, what would you have voted if you had the option?
Yeah, I would have wait and watch and done more analysis. And I was also wanted to ask if there was any occasion that you needed thrombopoietin agonist. You mentioned is an option, but with more than 75,000 platelets, probably is not needed, no, right? So.
Correct. Yes. I mean, I would agree, but I'm interested, given that he enjoys rugby and judo, that at some point you might regret that decision, irrespective of the uncle being a professional rugby player and not having any treatments either. But yeah, now we have it as an option if they want to be a very active boy. Should we try to aim for normal?
So, Lizzie, what's been your advice to him about head injuries?
Yeah, that's tricky. Urgent medical assessment in the event of a significant head injury, and watching for a pattern leading up to that if he's developing more in the way of bruising or bleeding, not in the context of his contact sports, that he needs a reevaluation for what's his platelet status. But yeah, quite tricky and medically difficult to actively encourage rugby in these patients, but yeah, hard.
Okay, great. We're going to move on. I see that there's a question come in saying, why did I ask about consanguinity? I guess it was just if we're thinking about other diagnoses, non-Wiskott. That was the reason for that question, and because somebody had actually put it in the chat. Okay, so we are going to move on, and Khuloud Alsehaim is going to present our next case, which is an adult case. Hopefully, Khuloud, you... yeah, there you are. If you can put your camera on, Khuloud, and your microphone off, and if you can share your slides, if you can get into presentation mode, that would be helpful. Yeah. You're still muted, Khuloud.
Can you hear me?
Yeah, we can hear you. Okay. We can hear you, but we don't see your slides now.
Yeah.
Hold on one second. Yep, and can you put them, if you can't put them in presentation mode, just go with what you have. But if you can put them in presentation mode, it should be the...
Can you see it now?
We can, but you're in a mode where we can see the slides down the side as well.
I can share the presentation.
I think, Susa, the problem with that is Khuloud has a lot of animation in hers, and I think if you share it, we're going to be quite slow. So I think it might be better for Khuloud. How do you want to do it? Do you want Susa to share, or do you want to share your own again?
Yeah, I can try it again. See.
Yeah.
Can you see it this way?
Yes, that's better. That's much better. Okay, so go ahead.
Sorry for that. Thank you for giving me such an opportunity. It's a great pleasure to be here. So I'll be presenting a complex and interesting case of Wiskott Aldrich, who was treated here at the Royal Free Hospital. So our case has started his symptoms since birth, and between that and the age of 3 years old, he had history of recurrent chest infections, severe respiratory failure requiring tracheostomy, severe eczema, thrombocytopenia, and eventually he was diagnosed with Wiskott Aldrich Syndrome. At the age of 6 years, he underwent hematopoietic stem cell transplant. He had it from 10 out of 10 matched unrelated donor. He was conditioned with ATG, busulfan, and cyclophosphamide. He had mixed chimerism with poor platelet counts from 30s to 40s, and post-transplant complications was only transient skin GVHD, but nothing major. So following transplant, his chimerism was 70% of donor T cells, 26% for donor B cells, and only 2% for donor myeloid cells. Patient continued to be reasonably well with no significant symptoms apart from breakthrough herpes simplex virus infection, which was controlled with antiviral prophylaxis. He had his platelet maintained between 20s and 40s with no active bleeding, and he had occasional episode of mild intermittent eczematous rash. So at that point, the discussion was whether we go for another hematopoietic stem cell transplant or CD34 stem cell top-up. However, the original unrelated donor became unavailable, and no other related donor was available at that time. So following that, and between the age of 10 years till the age of 21 years, he continued to have no history of infection, no active bleeding, and his platelet maintained between 20s and 40s. And at the age of 10 years, he was diagnosed with hypertension. And at the age of 16, he had an episode of eczema, which was severe, but responded well to phototherapy. So following that, and at the age of 22 years, he had presented with flu-like symptoms, lethargy, and hematuria. He noted to have stage 2 renal acute kidney injury and nephrotic range proteinuria. He had progressed to stage 3 AKI, where he was discussed for renal biopsy. However, it deemed as contraindicated due to his underlying thrombocytopenia. He empirically started on high-dose oral steroid for presumed diagnosis of nephrotic syndrome, and despite 6 months of steroid, he continued to progress to chronic kidney disease, stage 4. So eventually, he underwent renal biopsy, which confirmed IgA nephropathy. He continued to progress and started on MMF as a steroid-sparing agent. So following that, and between the age of 23 till the age of 24 years, he failed the treatment and progressed to end-stage renal disease, requiring dialysis. He had, in terms of his immunodeficiency, no significant infections or eczema. His platelet remained between 20s and 40s, and he had got only nosebleeds with no major bleeding. So second mud allograft renal replacement therapy deemed inappropriate due to difficulty in delivering chemotherapy conditioning. So the discussion at that time was whether we go for renal transplant first or bone marrow transplant before that. So the first option was a sequential living donor renal transplant, followed by haploidentical hematopoietic stem cell transplant, potentially from his mother. The limitation for this option was it was 2 major procedures for both the patient and donor. So the second option was renal transplant and wait and watch approach for a later allo stem cell transplant. The limitation for this option, one, was the impact of post-renal transplant immunosuppression on his immune function and worsening of infections. 2, the recurrence of IgA nephropathy. So before I move to our decision, so I would like to hear from the audience what would be your option out of these 2. So I'll give it a few seconds for everyone to vote for that. I don't know, I can't see the answer.
Susanna, is the poll finished? Can you put up the answer?
People are still voting. I will just give them a couple more seconds and then display the results. Yep.
Please let me know if it's done because I can't see it here.
Yeah, the results are on the screen.
The results are 57% in favor of a sequential living donor renal, followed by haplo stem cell transplant for mother, and 43% in favor of a renal transplant with a wait and watch approach for a later allo.
Oh, so almost near each other. So our option was renal transplant and wait and watch approach for a later allo transplant. The justification for this option was estimated mortality for both options. So for the mortality for stem cell transplant after renal transplant was around 20%, while the mortality for renal transplant was estimated around 1 to 2% based on regional data. In terms of recurrence for IgA nephropathy, it was estimated around 10 to 15%, which would be probably higher in NOAS. The other thing was the duration of renal graft survival, which was estimated between 10 to 15 years. So at the age of 26 years old, our patient underwent living donor kidney transplant from his mother, and he was started on tacrolimus and MMF, and he was electively started on immunoglobulin replacement therapy. So following that, between the age of 26 till the age of 32 years, he further declined in immunology parameters. He had poor vaccine responses. His chimerism showed T cells around 58% and B cells around 15% and 0% of donor myeloid cells. Subsequently, he had recurrent respiratory tract infections with declining lung function. He eventually required long-term immunoglobulin replacement therapy. So here we can see his CT before and after renal transplant. The one on the left is before transplant, and the one on the right after transplant, where we can see the bronchiectasis, obviously. So currently, he's at age of 32 years old. He progressed to CKD stage 3 and anemia requiring EBO. He was discussed for renal biopsy, but it will be planned after platelet optimization. So key points we learned out of this case is 1, early consideration of hematopoietic stem retransplant for low chimerism before complication progression or graft failure. 2, continuous close monitoring for any disease-related complication in the absence of full disease correction, and eventually the need for continuous experts and multidisciplinary team discussion. Thank you.
Thanks, Khuloud. That's great. Michael and Alessandro, could you turn your cameras on? And thank you. All right. So Michael's already got his hand up. That was quick. So I'll let you ask Khuloud some questions first. Go ahead.
Thank you. I had the slides before, so I knew what I was going to ask. One question: do you have the busulfan AUC this patient received?
I don't think so. It was a long time ago, so I don't.
Yeah, we don't, because he was actually not transplanted in London, so we don't actually have a lot of the kind of early history. Yeah.
Yeah, but clearly it must have been too low because he had a failed myeloid engraftment.
So how do you avoid that, Simi, as you brought up the busulfan AUC? Michael, do you want to explain what that is and what you aim for if you're transplanting patients?
Yeah. I'm not saying it can always be avoided because that would not be true, but we would certainly aim for at least 85 to 90 in such a patient, depending on age, a little bit higher in the small ones. In any case, I believe this patient should have had a retransplant early from his original donor, and in the setting that you described, which is actually quite typical with still prevalent donor T-cell chimerism, but absent myeloid donor chimerism, he could have received a busulfan-only retransplant at a CD34 selected graft without any immune suppression, without any fludarabine or cyclophosphamide, because he only needed myeloid engraftment and no more T-cell or B-cell engraftment at the moment. And that may have saved him from the tragic course later.
Yeah, and I was going to ask Michael, I guess that is an easier thing to decide upon before you've started to run into problems with the renal impairment.
Yes.
Which then complicates things in terms of conditioning, etc. We'll maybe come back to that. There are some questions in the chat which we'll come back to a bit later. But Alessandro, do you want to give your comments? How would you have? Well, actually, give your comments first. Then I'm going to ask you both a question about how you would manage it now.
Yeah, I mean, now is very difficult, but the question, the comment is, I would agree with Michael to go earlier. Also understand that doing a retransplant, it's in a patient is not always easy to reconsider, but there are pros and cons. No, my question is whether the sleeping chimerism also in the lymphocytes after the renal transplant, do you think it's due to the immune suppression? I mean, you basically, it was lost any mild chimerism, but I think there was also a decrease in the donor lymphocytes, which is, do you think it was due to the immune suppression or the graft?
That's a good point, which I don't know. And Khuloud, I don't think that we've made any specific. We've had a specific comment about what's the cause of the slipping chimerism. In your experience, Alessandro, is that usually what happens if you have to use immunosuppression following transplant, that you get worsening of donor chimerism?
I mean, it's of course it depends on which direction goes the graft versus host of the rejection. So it's certainly disturbing the balance, and
Yeah.
in principle you should still have your selective advantage, but I wonder whether you lose some of the selective advantage under immunosuppression, and therefore it's rebalancing towards more host was defective cell population, but it's difficult to predict. It was just trying to find a cause for that.
Yeah. Thank you. So both of you, both Michael and Alessandro, what would your advice be to us now?
If he's still able to, I would go to transplant now, but he has extremely high risk. And we would have probably gone to a stem cell transplant first and then renal transplant after, because the probability of the nephropathy reoccurring in the transplanted organ was quite high in a Wiskott patient, and the kidney is a much more valuable graft because the mother obviously cannot donate her second kidney.
Yeah. Alessandro, what would your advice be at this point
or
previously?
No, I mean, I agree with Michael. Probably this would have been an alternative strategy. Of course, there are pros and cons, so it's difficult. The answers were 50-50 for. So I understand that it's always a difficult choice, but this could have been an alternative from earlier strategy. Yeah.
Yeah, and I think the discussion at the time, we had extensive discussions with transplant renal team and the family, as well as immunology. And at that time, although this was quite a long time ago, it wasn't felt that he would be, by the time we were analyzing or doing all of this, his renal function was already so poor, the transplanters didn't feel that they could deliver conditioning safely. And actually the advice from the transplant pharmacist was that the drug doses would not be it would be very difficult to predict drug doses. So that was why the transplant wasn't done at the time. I think you are correct then. I guess the challenge is once you've put in a nice new kidney, it's much more challenging to then deliver a whole pile of chemotherapy, although it's easier to deliver the chemotherapy. It's just a hit to the kidney. I suppose there is a separate thing, which is ultimately transplanted kidneys don't necessarily last forever, and whether or not, in fact, if you're going to do a temporary thing like this as a wait and watch, you're better off not to use a living donor, like a family kidney. The advantage of the family kidney is it lasts longer, obviously, and it's a living donor, but there are disadvantages in then tying off other options for later on. Complicated. Any other comments?
Yeah, actually the patient would still be eligible, I believe, for a myeloablative only conditioning without putting him at risk for all the immunosuppressive drugs further damaging his kidney. That's the one comment I would make. But clearly now at this point, it's a very risky procedure, but the alternative being more palliative approach, it could still be considered. Can I just one other thing to the people, please do not put your questions into the webinar chat because we cannot reply to them there. Please put them in the dedicated Q&A section.
And there are quite a lot of questions that have come in. I'm conscious that we're not answering them all now. It doesn't mean we haven't seen them. We will circle back to some of these questions at the end. All right, I think let's move on because then we will know how much time we have left to discuss all the questions that have come in. Khuloud, thank you very much. So we're going to now hear from Francesca about an update on gene therapy for Wiskott, and you're going to show us some of your very nice results. Thank you.
Thank you very much. Good afternoon, everybody. First of all, I would like to thank the organizer for this invitation to this very interesting Grand Round today. And the aim of my today presentation is to provide you with an update about the current state of the art of ex vivo hematopoietic cell gene therapy for the treatment of WAS. Ex vivo hematopoietic cell gene therapy consists of the infusion of genetically modified cells that reconstitutes the hematopoietic system with the engineered progeny and may rescue a disease pathogenesis up to a cure. Gene therapy is a process starting from the harvest of hematopoietic stem and progenitor cells from the patients, either through bone marrow harvest or mobilized peripheral blood through leukapheresis after mobilization with G-CSF and Plerixafor. Patients' CD34 positive cells are then selected and cultured for a few days in the presence of cytokines and the vector carrying the transgene. At the end of the transduction process, the cells are either fresh infused back to the patients or cryopreserved for a later infusion. Intensive QC testing is usually performed before the release of the drug product. And before infusion to the patient, most often a conditioning regimen is administered to the patient to allow a sufficient engraftment of gene-modified cells. Because the conditioning depletes the resident hematopoietic stem cells from the bone marrow to make space for the new gene-corrected infused cells, it establishes a transient myelosuppression that exposes the patient to the risk of infections and bleeding, and as it occurs with autologous of allogeneic HSCT. Gene therapy is indeed a personalized living drug, and there is no risk of GvHD because it's an autologous procedure. But what about gene therapy for the treatment of WAS? After extensive preclinical studies, proof of concept for the feasibility and efficacy of gene therapy for the correction of WAS disease was highlighted now 15 years ago with the publication of the results of the first clinical trial of gene therapy using a gamma retroviral vector under the control of a strong viral promoter. Despite proving the efficacy of gene therapy in correcting the disease phenotype, this approach also highlighted the high risk of insertional mutagenesis and leukemia development using such a strong viral promoter. To overcome the safety hurdles, parallel clinical trials using lentiviral vectors started in Milan and in other centers, and preliminary safety and efficacy results were published in the later years, and more recently, long-term follow-up confirmed the first observations. As already mentioned by Michael in his presentation, multiple clinical trials based on lentiviral hematopoietic cell gene therapy have been performed both in Milan and in other centers in France, UK, and in the US. In these trials, the lentiviral and the transduced cells were manufactured at different sites, but the vector design was the same. Indeed, for these clinical trials, a self-inactivating lentiviral vector encoding was for the human WAS cDNA driven by a 1.6 kb promoter fragment of the endogenous WAS promoter was selected for increasing the safety of this approach. Treatment consisted of a single infusion of lentiviral transduced autologous bone marrow or mobilized peripheral blood CD34 positive cells after conditioning. In Milan, at San Raffaele Tiget, we adopted a reduced intensity conditioning regimen with the aim to minimize toxicity and to fully exploit the selective advantage of gene-corrected cells, while in the other centers, a more intense regimens were adopted. Moreover, in Milan trials, all patients receive a single dose rituximab 3 weeks before infusion of gene-corrected cells with the aim to deplete potentially autoreactive B cells. As of 2024, a total of 47 patients have been treated with gene therapy, with a follow-up reaching more than 10 years in the first patients treated. Overall survival is 94%, and the 3 patients who died because of morbidities, but not because of gene therapy-related causes. The majority of treated patients experience a significant improvement in immune function and the reduction of severe bleeding events thanks to the improvement of thrombocytopenia. To date, no severe gene therapy-related adverse events occurred. No treated patients developed any leukemia, clonal proliferation, insertional mutagenesis, or replication-competent lentivirus. I will now focus on the Milano cohort, in particular on the clinical development of etovetinib autoimmune cell, or Teleton 003, which is a gene therapy product composed of autologous CD34 positive HSPCs transduced ex vivo with the self-inactivating lentiviral vector encoding for the human host cDNA under the control of the endogenous promoter I just mentioned before. A total of 17 patients have been treated with the fresh formulation of TLT003 between 2010 and 2019 at San Raffaele Hospital in Milan, 8 patients within a phase 1/2 clinical trial, and additional 9 patients within an expanded access program. Later on, 10 male patients were treated with the cryopreserved formulation of Teleton 003 between 2019 and 2022 in the context of a new phase 3 clinical trial that was run in 2 centers. 9 patients were treated in Milan, while 1 patient was treated at Children's Hospital in Atlanta in the US. The safety profile of this approach was reassuring, with an overall survival of 96%. 1 patient from the expanded access program died 4 months and a half after gene therapy due to the deterioration of a pre-existing neurological condition considered not related to the gene therapy, while all the other subjects are alive and well. To date, no report of TLT003 related adverse events, nor suspected unexpected adverse reactions have been observed, and no evidence of insertional mutagenesis or abnormal clonal proliferation or replication competent lentivirus were observed, as well no signs of immunogenicity. The sustained engraftment of genetically modified HSPCs was confirmed throughout the follow-up up to latest time point, both in bone marrow and peripheral blood, and this resulted in the restoration of host expression both in lymphocytes and platelets that was sustained over time. The restoration of host expression in lymphocytes resulted in a T-cell function normalization after gene therapy, and immune reconstitution allowed all patients to reach freedom from sustained immunoglobulin replacement therapy and sustained antimicrobial treatment at a median of respectively 12.6 and 14 months after treatment. Importantly, despite suspending prophylaxis, after the first 6 months of follow-up, a substantial reduction in the rate of severe infections was observed in all patients during the follow-up up to the latest time point, and eczema resolved in all patients, and pre-existing autoimmunity was resolved after treatment, and as you can imagine, this reduced the time spent in hospital by patient and impacted positively their quality of life. Patient-wise, the restoration of host expression in platelets not only resulted in improved platelet count, but also in improved platelet function, with normalization of platelet hyperactivated phenotype, as nicely demonstrated by the group of Anna Villa some years ago. And both the normalization of platelet function and improvement of platelet count resulted in freedom from platelet transfusion after gene therapy at a median of 57 days after treatment, and importantly, in protection from bleeding events, as evidenced characterized by the reduction in both the severity and the rate of bleeding events after the first 6 months of follow-up up to the latest time point. Interestingly, gene therapy proven to be effective also in taming the flame of autoinflammation in WASP patients with control of autoinflammatory manifestation thanks to the gene-corrected myeloid cell engraftment. In this regard, I would like to briefly show you a case of a 20-year-old patient with a clinical phenotype characterized by very severe treatment-resistant Crohn's-like enterocolitis and awful pyoderma gangrenosum and perianal fistulae and abscesses. Sorry for the images, but they are very illustrative. This was the patient while on heavy immunosuppression. When he arrived at our center, we started off-label anakinra, and thanks to this, autoinflammatory manifestation improved dramatically. But also the use of anakinra allowed us to treat patients with gene therapy because it could underwent mobilization with GSF without recurrence or actually worsening of autoinflammation. And we continued anakinra up to the first days after conditioning and infusion of gene-corrected cells. And indeed, this is the patient 7 months after gene therapy with autoinflammation very well controlled and off any immunosuppression. And during the follow-up, it did not show any recurrences up to now. So in summary, as of May 2025, we have treated a total of 33 patients with Teleton 003, 32 of them are alive. Immune reconstitution and discontinuation of prophylaxis were obtained in all the patients. Improvement in autoimmunity and eczema also impacted on the quality of life of the patients, together with the protection from the bleeding events. No gene therapy-related adverse events or clonal dysfunctions were observed, and the cryopreserved product behaved similarly to the fresh product with a similar safety and efficacy profile. Based on this data, we can say that gene therapy compares favorably with hematopoietic cell transplant in the absence of GVHD and graft rejection. I take the occasion to say that we have summarized most recent data in an abstract that was sent to the American Society of Hematology meeting, and we are going to present it there in December. Before concluding, I would like to focus on adult patients. As mentioned in previous presentation, many adult WASP patients whose clinical phenotype evolved during time from less to more severe would benefit from transplant, but it's often this option is often limited by limited donor availability and hampered by ongoing organ damage or infection, and is still associated to a less favorable outcome. So as a consequence, hematopoietic stem cell transplant is evaluated on an individual basis for each patient, and gene therapy is emerging as a tailored therapeutic alternative with potentially a more favorable benefit-risk ratio for this patient. With regard to this, I would like to show you very briefly our experience with 2 adult brothers that we published some year ago together with Giulia Consigliere and Maria Pia Cicalese. And these 2 siblings present a very peculiar case because, of course, they share the same WASP mutation and similar clinical phenotype. And one underwent hematopoietic stem cell gene therapy, and the other one underwent matched sibling donor allogeneic transplant. Patient 1 was the firstborn. He was diagnosed at the age of 8 years and developed because of thrombocytopenia and bleeding, and was splenectomized because of this. And at the time, it was considered as a mild WAS in brackets. But at the age of 22, he developed vasculitis. At that time, because of the deteriorating clinical picture and the lack of an available donor, he was candidated to gene therapy and treated with this approach at 27 years of age. The brother was diagnosed in parallel with the first brother and was also splenectomized at 5 years. Interestingly, the vasculitis occurred earlier than in the patient 1, but being available a non-carrier fully matched sibling donor, this patient was candidate to matched sibling donor transplant. Very quickly, the patient would receive gene therapy, underwent one single dose of rituximab on day -22 and reduced intensity conditioning regimen with fludarabine and busulfan, while his brother underwent bone marrow derived stem cell transplant, and he received fully myeloablative conditioning with treosulfan, fludarabine, and thiotepa. Both of them engrafted very well in a timely manner. And tolerated the procedures quite well. Patient 2 developed grade 1 acute GVHD in the first months after treatment that triggered some nasty cutaneous lesions that were poorly responsive to current multiple lines of immunosuppression. Because of this, and also because concomitant very high titer of IgE, a different etiology was hypothesized. So dupilumab was used and with very prompt clinical benefit and disappearance of skin manifestation. Both of them engrafted very well. Patients who underwent bone marrow transplant reached full donor chimerism, and patients who received gene therapy attained a very good and adequate multilineage engraftment in both peripheral blood and bone marrow lineages. Immune reconstitution was achieved in both patients with early discontinuation of immunoglobulin supplementation in the gene therapy treated patients, and platelet count, which had already raised after splenectomy, further raised and were maintained in normal range through the follow-up. Quality of life improved in both patients during follow-up after transplant and the gene therapy. So what I wanted to highlight with the experience from this clinical report in these two adult siblings treated with the gene therapy or transplants is that a similar efficacy and safety profile can be reached with both therapeutic options together with the maintenance of a good quality of life throughout the entire follow-up. This case highlights the current availability of an increased range of possible treatment options also for adult patients, and the choice for the most appropriate treatment should be tailored on the single patient based on donor availability and careful evaluation of patient-specific risk-benefit profile. In summary, currently available safety and efficacy data show the potential of lentiviral ex vivo hematopoietic gene therapy to be an effective life-changing treatment for patients with WOS. And these results were obtained across multiple clinical trials of lentiviral gene therapy, showing the excellent survival and response rates with a very good safety profile. But of course, beyond the safety and efficacy, lentiviral gene therapy treatment should be also accessible and sustainable. And to this end, at the moment, treatment with the tubetiligen totem cell is currently available under the Italian 648 law for Italian and EU patients aged more than 6 months, having a mutation in the WOS gene with a severe form of WOS and lacking a suitable related HLA identical donor. Last year, Fondazione Teleton submitted application to a EMA for EU marketing authorization and to FDA for BLA in the US. So we are waiting for their response in the near future, so finger crossed. And this is the huge team in Milan that I would like to thank because of their dedication to this project. And I would also like to thank you all for your attention. And I will be happy to take any questions.
Great, thank you very much, Francesca. Michael and Alessandro, initially, do you want to just turn your cameras on for any just discussion about this? I've got a question about gene therapy, and the results are looking really nice. In practice, how widely available is gene therapy as an option for patients, and what's a mechanism by which teams can refer patients for gene therapy? Or is this all still very kind of limited clinical trial availability?
At the moment, we can accept Italian or EU patients through this law that I mentioned, that is a kind of special law that in Italy allows to provide treatment with demonstrated efficacy and safety before their approval, but I really hope that in the very near future, if we got approval from the EMA, this approach will become an approved drug and available for EU patients and hopefully also for US patients for the moment. So we are waiting. I think it's gonna be something that should come in the very near future. So hopefully the accessibility for patients will be much wider than what was in the past in the context of clinical trials.
Okay, maybe a question for both you and Alessandro. In terms of gene therapy for adults, I guess the challenge for adults is they're much bigger than kids, therefore need a lot more vector, and I guess those are part of the reasons for why clinical trials haven't really been so available for adults for gene therapy. How do you see that going forward? Do you think there's going to be equal application of gene therapy for pediatric and adult patients, or not, because of practicality around vector amounts and costs?
Shall I answer? Okay. No, I mean, it's that's a very important question. So, the trials were open both for pediatric and adult, and we have treated also adult patients, few, but this would represent also, you know, the overall population. And I think adults could be a good candidate for gene therapy, and it's also considering that this is a reduced intensity conditioning. I don't think that the vector would be a problem, because if the product would be an approved product, this would be available regardless of the weight of the patients, and so it would be accessible to all patients, and that would open, of course, a new wave, and based on what would be the criteria of eligibility, which are not yet defined. And so I think we will need to answer in a few months from now on the actual accessibility and for patients. But we are confident that both adult and pediatric patients could access to gene therapy.
And a question maybe from Michael. Michael, where do you see decisions in the future going between stem cell transplant and gene therapy? Do you still think there'll be a do you still think there'll be a HSCT first approach, or a very much depends on what's available approach? Where do you see the decisions going?
Yeah, thank you for this very easy question.
No problem.
No, I don't. I mean, very likely matched sibling donor transplant will still be the gold standard and remain the gold standard, especially for pediatric patients. But for all other patients, I think it will really come down to discussing all the pros and cons, and that's why I put that slide, comparing the two modalities, because I don't think we will be able to tell each and every patient whether they will likely fare better with transplant or fare better with gene therapy, because it could be either way. And but clearly there are differences and advantages and disadvantages. I think it'll just augment our armamentarium that we can offer to patients. It will make discussions even more difficult, but at the end, it's a good thing.
And is the conditioning chemotherapy sufficiently different between the two regimens that for patients with, for example, other end organ disease, one or other would be preferable?
I think Francesca can answer that better.
Thank you. I did not mention for the sake of time, but I think that the target to busulfan AUC we use in gene therapy is 48,000. It's kind of more or less the half of what is used in myeloablative conditioning, full myeloablative conditioning. And I think that that is very well tolerated. We did not observe any peculiar consequence of conditioning. It was really very well tolerated by the patients. So I think that's important in patients with end organ damage, because it can increase the chance to tolerate the toxicity of the conditioning.
Yeah, but sorry, actually with transplant gene therapy, the conditioning is relatively similar, but in transplant, you also need immunosuppressive drugs, and they can be quite toxic. And you can only avoid them if you use very deep T-cell depletion. So this, I think, is even more important than the difference in conditioning, which is relatively minimal.
Also, in terms of, I agree with you. Thank you for bringing this out, because also in terms of chronic CMV, that is sometimes nasty complication in Wiskott patients, having the need to have immunosuppression after transplants increase the risk of viral activations in the early follow-up that we usually don't see without any immunosuppression after gene therapy.
I'm going to ask you one last question, Francesca, just about kind of long-term effects, I guess, of the gene therapy process, particularly with related to fertility. So what's your prediction about fertility with the conditioning, or do we take that if both gene therapy and transplant have quite similar conditioning, the impact on long-term fertility is going to be quite similar between the two options?
Actually, we are collecting data about this, so I still don't have an answer, but I hope that in the future we are going to see some difference with this aim, because often families ask us about this question, so it's very common, but we still don't have data to answer at the moment.
Okay, thank you. Alessandro, do you want to say anything else about gene therapy specifically before we move to a more general Q&A?
No, thank you.
Okay, that was quick. I'm going to suggest that all the speakers turn their cameras on, and that we maybe go to Susanna. Can we go to a tiled view so that all the speakers are similarly visible, or is that not possible?
They already are.
Okay, maybe it's just my screen. Okay, so let's then move on to the questions that have been put in the chat. You can, if you've still got questions and you haven't put them into the chat yet, if you can do that, and we'll do our best to answer things. Some of the questions are about very specific cases. We might not delve into the details of very specific cases, but give some general principles about how we manage specific aspects. So I think one of the questions that's come up from several people in the chat is around autoimmunity, and particularly IgA nephropathy. Maybe particularly Michael and Alessandro, how do you approach managing autoimmunity in general in Wiskott? And more specifically, what's your approach to patients with IgA nephropathy? Who would like to go first?
I will let Alessandro go first this time.
Okay, Alessandro.
This is also an easy question.
Off you go. If you want to deal with general approach to autoimmunity first, do you consider all autoimmunities to be similar in terms of indicating a severe form of Wiskott? Is any autoimmunity equals severe Wiskott in your case?
I guess it depends on the organ, whether we are talking about inflammatory bowel disease, cytopenias. So it really depends. But in principle, yeah, I would any autoimmunity would classify it. Clinical autoimmunity would classify as a severe form.
Okay,
and
so to kind of clarify, then, as a general rule of thumb, autoimmunity would make you think about curative therapy if that hasn't already been thought about. Is that fair?
Yeah, that's fair. Yes, because
okay.
It means that the imbalance of the immune system is not going in the wrong direction, and you need a curative treatment. Yes.
Okay. And in particular, do you have any specific kind of protocols or pathways for IgA nephropathy? How do you generally manage this at your center? Wiskott patients with IgA nephropathy.
Yeah. We don't have any specific protocol. I would say that in general, we would need a balance between immune suppression, use of biologics, and so it's it's really sometimes a vicious circus way, because you start immune suppression, immune modulation, and you can get more infection or reactivation. So it's that's why it's the earlier you get towards a definitive treatment and you reset this balance, the better, because we have experience not necessarily with IgA nephropathy, but with other cases that in which you have you get worsening or then organ damage, which you don't want to go. Yeah.
Okay. So as a kind of general, without, I mean, appreciating that there are nuances between cases, as a general rule, are you usually thinking that if you have IgA nephropathy, you will be thinking about some form of curative approach down the road? Michael's nodding his head and got his microphone off mute. So what would you like to say, Michael?
Yeah, I would just add to that, as you indicated, IgA nephropathy for us is probably the most severe form of autoimmunity and was, because it will signal that a very critical organ is about to be damaged. And in our experience, while the course of this nephropathy can be very different in between patients, in general, there will be a tendency for it to get worse. And some patients can even progress very quickly, like within a year, to a very severe form of kidney insufficiency. Therefore, for us, this would give a more urgent signal to go towards a definitive therapy, while, for example, something like vasculitis of the skin is also a sign that there's a disbalance in the immune system that signals this patient may need definitive therapy. It may just not be that urgent, because skin is not such a critical organ.
Okay. And maybe this is a good point at which to discuss how people manage patients with multi-organ problems in a kind of multidisciplinary way at their centers, because I'm assuming, Michael, you don't manage the IgA nephropathy necessarily yourself. So how do you approach management of a Wiskott patient? How do you pull in other people? How do you coordinate discussions, etc.?
I think this question was also for me, right? Or mostly for me. So I think this is especially important in adolescent and adult patients. In pediatric patients, it's usually easier because you only have the parents to deal with, and it's still a pediatric case and with less multi-organ involvement. But in the adolescent and adult patient, it's critically important to have the respective specialists on board, be it a kidney specialist or an immunologist or a transplanter or a psychosocial worker of any profession. And I think that's critically important, and it's more and more appreciated that this needs to be really a team approach to the families. Sorry, you muted, Siobhan.
Thanks, Michael. I was going to say thank you. Do any of the other speakers want to add anything to that? No. Okay. Let's move on then just to talking about, there are a lot of questions about conditioning and whether you should have ablative conditioning, non-ablative conditioning, what's the status of medium conditioning post-transplant cyclophosphamide. Michael, do you want to talk about approach to conditioning what are the principles, or is there a very strict protocol everybody should be following?
No, there is not. That's actually a good question, because no, there is not. I would only say, as we have seen also from the case presentations that we saw, that achieving complete myeloid donor chimerism after transplant is the ultimate goal. And patients with Wiskott do not have any bone marrow insufficiency or bone marrow failure. So they, in general, require fully myeloablative conditioning to get there. Having said that, younger patients, so especially toddlers, young toddlers, are known to need higher busulfan exposure in order to reach fully complete myeloid donor chimerism. So, and since the average or median age of transplant in Wiskott patients is something like 1.5 years, we believe that these young patients need a fully myeloablative busulfan regimen to have the best chance of cure. Clearly, this is different in the adolescent or adult patient with potentially with organ damage, but even without, they will clearly need less intensity of conditioning to reach that goal. So it'll always be a decision of the transplanter together with his team what to use. And also with PT-Cy, it's possible that a lesser degree of pre-transplant conditioning is necessary if you give cyclophosphamide after the transplant, but there are no good studies that have really proven that concept yet.
Oh,
maybe I can add about the gene therapy conditioning. Well, in the sense that this, as we discussed before, this is saying that of course reduce intensity with no immune suppression, and you achieve situation in which you have mostly of the lymphocytes which are corrected, but about half of the myeloid cells are corrected in the stem cells and engraftment. And this is sufficient in the autologous context to allow platelet improvement, but also for to cure the autoimmune disorders and to inflammatory disorders. So this situation of let's say mixed chimeras in the autologous context is sufficient. It's probably a different situation than the allogenic ones where you need a stronger engraftment of donor cells because maybe the HLA disparity is also important. And interestingly enough, once we have the engraftment, this is quite stable over the years, as you've seen. So there is no tendency of sleeping chimerism, or let's say of corrected cells. So it's again, it's another difference with the autologous transplant compared to the allogenic ones.
Thank you both. Sorry about that. I was going to say I'm going to move on to talk about carriers. Just before we talk about kind of management of carriers in general, I wanted to ask Alessandro and Michael whether or not you use carriers as donors for patients with Wiskott Aldrich syndrome when you're considering bone marrow transplant, or do you try and steer away from that?
Okay. So I would say that in general, we tend to avoid a carrier if possible. It's a balance. Usually carriers have, let's say, half of the cells which are normal, and there could be a selective advantage for the wild type cells. We know that there are few carriers who have some abnormalities in the X inactivation. So I think again it needs to be discussed case by case on what is the general availability of also other donors, I would say.
Michael, do you have a position on this?
Very similar. So if we have the choice, we will avoid a carrier donor. If we don't have a choice, we will look at X chromosome inactivation, and if it's random, then we will use this as a donor happily if it's a woman without any symptoms. And as a quick test, you can test the platelets. If they have 300K platelets and are without symptoms, they are usually fine, and we happily use them as a donor. But if we have a choice, for example, 2 matching sibling sisters, one of them is a carrier, we always use the non-carrier.
Thank you. Michael, I'm going to give you a task while I ask the next question. As my computer just rejoined there, I actually can't see any of the old Q&As. Could you just have a look and see what other ones? A few of them are for you around various aspects of mainly transplant. So maybe just have a look and see what we haven't answered. And in the interim, I was going to ask Alessandro and the other speakers, because people may have some experience of this in their own centers. What's your approach for carriers? Do you provide any medical input for carriers? Do you generally advise that carriers are well lifelong? Do you provide any psychology input? What is your approach for managing carriers of Wiskott? Alessandro, do you want to start?
We provide genetic counseling and general counseling about the disease. I would say that we don't do regular clinical monitoring unless there are, again, the few cases in which female carrier may have symptoms. So I know that there are some studies which we did a study in which we interviewed some of the carriers and found some clinical manifestation, mild clinical manifestations, but this is needs to be extended to a larger population. So, and again, in few percentage, you will find you may find lower platelet counts due probably to this abnormal X inactivation. But in general, they have healthy carriers should have a normal life. Yeah.
Okay, thank you. Michael, do you have anything different that you do at your center?
No.
And Lizzie, how about you?
No, not really. I agree. Referral to clinical genetics and think about a discussion about PGD if that's something that's available or of interest to their offspring. But in terms of counseling them themselves as carriers, no, generally reassuring. And you can usually identify those that rarely have symptoms quite easily.
Okay. And PGD, you're meaning prenatal genetic testing for?
Yes.
Yeah. Okay.
Yeah.
Michael, were there any questions that we did not cover in the
Yes.
from the original chat? Okay. Do you want
Yes,
to dole them out then?
There's one easy question which I can direct at you and Lizzie maybe. IG replacement therapy, do you do subcutaneous or IV, or are you afraid of bleeding when using subcutaneous?
Good question. Lizzie, do you want to speak about that?
Yeah, good question. We don't see significant problem with bleeding, and we certainly have offered SCIG to those patients where it's available. Yeah, I think you have to balance the repeated cannulations and not having a central line. And I think holistically, that's very important to consider. But no, we haven't seen significant bleeding problems.
Same here. Yeah.
Yeah, and I would say the same for the patients that have come through to adulthood without transplant. I think that all of ours are having subcutaneous treatment without any problem.
Yeah. There was also one question about fertility studies post transplant. That's actually a tricky question because we do not have good data on fertility outcomes after transplant in general, because it would need, these studies are extremely difficult to do because we would need to go back to transplants done about 30 years ago or 25 years ago. And one, these patients are very difficult to find if they are alive and well, and B, the conditioning regimens we used 30 years ago would have been different from the ones we use today. For example, we would still have used cyclophosphamide, which we're rarely using these days, which is also an alkylating agent with a risk of infertility. So in general, we have to say that both transplant and also gene therapy will carry some risk of reduced fertility. We can just not pin a number on it. And certainly we have all seen patients who have become pregnant or fathered a child, even or in Wiskott fathered a child after transplant, after even myeloablative conditioning. But clearly there's a risk of decreased fertility, and Lizzie and Alessandro have their hands up.
No, I did for another question. Sorry, not on this topic.
Thank you. I was just going to add that we have offered cryopreservation to some of our patients, and we have had quite significant hematomas in these patients. I'd be interested to hear if you're doing the same at the other centres and if you've had the same experience that has on occasion delayed the start of conditioning for allowing platelets to recover before, to resolve the hematoma. But yeah, quite significant, quite significant.
Yeah, we have actually not done that in smaller boys, so I cannot comment on that, but I would also be afraid of that risk. Siobhan?
I was just going to mention that I guess we do have a big group of adults who've been transplanted across time for different immune deficiencies in pediatrics, and I think our counselling to all of them is that it's very often not easy to predict easily. So we prefer all of our adults who've had transplant as children for proper fertility input from our fertility teams. All boys will have a sperm test to see whether they produce normal, any, or no sperm, which then influences the options they have. And the girls will also be referred to check things like egg reserve. I think the other just important point is that early menopause is also forget that because we're talking about Wiskott today, but in general for long-term post-transplant, if girls have transplants early, as well as infertility, early menopause can be an issue.
Yeah, same as also we would recommend fertility and then cryopreservation of sperm in young adolescent and adult. Yeah, if you want to change the subject, there was one question about in utero stem cell transplantation or gene therapy available under consideration. This is not available or in utero gene therapy, and I think for transplantation there was experience in SCID where there was some benefit, although there was no advantage as compared to postnatal transplantation. So it's not considered, I mean, at least in my opinion, not an advantage over postnatal transplantation for a number of reasons.
I agree, because in Wiskott it's usually not an emergency situation. So even we tend to wait until our boys are at least 1 year of age before we take them to transplant, because most of them can be quite well managed with conservative measures until then, and then they have a good age to go to transplant. So there's no real reason to do such a high-risk procedure.
And then there is a question for Francesca Ferrua. Did your patient that you give anakinra and steroids have neutropenia or not?
No, the patient, I don't know if it was meant before or after treatment, but the patient never experienced neutropenia during anakinra treatment.
And you use it routinely also before mobilization of stem cell collection, and that's
yeah, that's actually I showed the more impressive case, but then we have used anakinra to control autoinflammation in other patients, and together with Lizzie we published few years ago now our experience in a cohort of 9 patients, demonstrating that anakinra or canakinumab, basically blocking IL-1, is very useful to control autoinflammation in WOS, and it's a very useful bridge treatment to transplant or gene therapy in these patients. Also because sometimes giving G-CSF for mobilization can trigger autoinflammation, so anakinra is very helpful in this.
Okay, Michael, I think if there are no more burning sessions, or burning questions, we should probably think about winding up, because we've got a couple of minutes to go and there are a few just announcement slides we need
Maybe
to
there is a question about TPO agonist routinely.
Yeah, maybe we should take
okay.
that and then
Yeah.
finish. Yeah,
Go.
Go ahead, Alessandro.
No, I mean, it's, they are now routinely used, although they have label. I mean, routinely, let's say, more often, because they can give some response. And so they are very useful, in our opinion, to bridge to a definitive treatment, because they can stabilize the patient, reducing the bleeding episodes, go to levels of platelets, which could be safer to undergo some procedures. There is a question mark about the long term, as was mentioned by Michael. So whether the response will be continuous, whether there will be some effects such as fibrosis, and what could be the long-term consequence. So this is remains an open questions, but has been a valuable tools, I think, for the short term.
Great, thank you, Michael. Did you want to add anything to that, or Lizzie?
Yeah, I would say we probably don't routinely give it for severe patients who we're going to transplant unless they really were getting difficulties with the low platelets and bleeding. But perhaps we would do that over splenectomy in these kind of cases now, knowing what we know about autoimmune thrombocytopenia and risk of relapse. So in more recent times we might do, but quite commonly can manage the patient without this if they're moving to transplant quite quickly. They might not need this. Okay, let's wrap up. And I'd just like to thank all of the speakers and the panelists for great discussion and great presentations today. I think that was a very informative session. Thank you for everybody who joined. I think we just have a few important announcements, so don't drop off just yet. I think one of the things that isn't going to be on the slides, but I'll tell you, is that the Wiskott Aldrich Foundation are currently coordinating the development of guidelines for Wiskott Aldrich syndrome, which hopefully will be available in the not too distant future. Other things to note are that the next Grand Round is on the 26th of November and will be about the spectrum of STAT1 defects, which will be a very interesting round. So do register for that. Susanna, could I have the next slide? And a reminder for ESID members, particularly juniors, that fellowships are open for application. Have a look on the ESID website, and deadline is soon, next week. So get on with it if you want to put one in and you haven't started your application. Next slide, Susanna. And then very importantly, later this month, it's a busy month for ESID, we are having a focus symposium on the interplay between immunology and hematology in Vienna. And if you haven't registered for this, I'm assuming there may still be places available, but have a look on the website. It's coming up soon. The conference is going to be focused particularly around areas of overlap between immunology and hematology. So things like autoimmune cytopenias, lymphoproliferation, bone marrow failure syndromes, for example. The program looks great. There's an educational session at the beginning on the 18th. So do have a look at the website and see whether you can get a place if you haven't already signed up. And for those that are signed up, we look forward to seeing you in Vienna. I think that's the end, Susanne, is it? Of the...
Yep, I guess it is. All right. Thank you, everybody, very much for joining. And we look forward to seeing you all next month at the ESID Grand Round. Bye-bye.
Thank you. Bye-bye.
Bye-bye.